All right, this is acute coronary syndrome, STEMI, NSTEMI, and high-risk chest pain. This lecture is about the emergency physician's job in the first minutes. Recognize the patient who needs immediate reperfusion, identify ischemia that does not meet classic STEMI criteria, start the right medications, and avoid the ECG traps that delay cath lab activation. The ECGs in this deck are original teaching schematics built from classic emergency medicine patterns with life in the fast lane used as a pattern reference and cited in the references. The objectives are straightforward. First, recognize STEMI, NSTEMI, unstable angina, and STEMI equivalent patterns. Second, use the first ECG and serial ECGs to avoid missing an occlusion MI. Third, apply emergency department ACS management, aspirin, anticoagulation, nitrates when safe, antiplatelet strategy, and reperfusion. Fourth, identify high-yield ECG traps like posterior MI, right ventricular infarction, Wellens syndrome, De Winter T waves, hyperkalemia, and pericarditis. And fifth, disposition correctly. Some patients need the cath lab now, some need ICU, some need monitored admission, some can enter a structured low-risk pathway. The emergency medicine mindset is that chest pain is a risk problem. The first question is whether the patient is unstable. The second question is whether there is acute coronary occlusion now or evolving ischemia. The third question is what therapy helps and what therapy harms. A single ECG and a single troponin are not enough when the story is concerning. The ECG is not a photograph, it is a movie frame. If the clinical story is high risk, keep filming with serial ECGs and repeat biomarkers. Acute coronary syndrome is a spectrum. STEMI means ST elevation or a STEMI equivalent pattern that should move the patient into an immediate reperfusion pathway. NSTEMI means ischemia with a troponin rise and fall. Unstable angina means ischemic symptoms without biomarker elevation, and it is usually managed as non-ST elevation ACS until risk is clarified. The key modern concept is occlusion MI. Some patients have an acutely occluded coronary artery without meeting strict STEMI millimeter criteria. That is why expert ECG interpretation, serial ECGs, and cath lab discussion matter when the story and the tracing are high risk. The most common cause of ACS is plaque rupture with overlying thrombosis, not gradual stenosis. That is the buzzword the board wants. The initial ED algorithm starts with ABCs, vitals, monitor, IV access, and a bedside glucose if the patient is altered or diaphoretic. Get an ECG within 10 minutes and repeat it if symptoms persist, worsen, or change. Give aspirin unless there is a true contraindication. Send troponin using your high-sensitivity pathway when available, but remember that the troponin is a time-dependent test. Risk stratification comes after immediate killers are considered. Acute coronary syndrome is central, but do not forget dissection, pulmonary embolism, tamponade, pneumothorax, and esophageal rupture. The board trap is discharging a high-risk chest pain patient because the first troponin is negative. In the first 10 minutes, the ECG must answer a practical question. Does this patient need immediate reperfusion or high-risk ACS management? Look for STEMI criteria and reciprocal change. Look for posterior MI, which may appear as ST depression in V1 through V3 with tall R waves. Look for inferior MI with right ventricular involvement because nitrates can harm that patient. Look for dynamic ST depression or T-wave inversion suggesting non-ST elevation ACS. And look for STEMI equivalents such as Wellens, De Winter, and modified Sgarbossa patterns. Finally, know the mimics: pericarditis, early repolarization, LVH, hyperkalemia, left bundle branch block, and paced rhythms. Classic STEMI is contiguous ST elevation in an anatomic territory, interpreted in clinical context. Symptoms, timing, reciprocal changes, and serial ECG evolution matter. If the ECG and story are a STEMI, do not wait for the troponin to activate the cath lab. Also, do not be trapped by the computer interpretation. The computer can miss posterior MI, subtle high lateral occlusion, De Winter, Wellens, and modified Sgarbossa patterns. The cath lab is activated for the patient, not for the machine read. This schematic shows an anterior STEMI pattern. Think LAD until proven otherwise. The key leads are V2 through V5, where you may see ST elevation and hyperacute T waves. Reciprocal inferior ST depression can also appear. Anterior STEMI matters because it involves a large myocardial territory and carries high risk for shock, ventricular arrhythmia, and heart failure. The emergency department action is immediate reperfusion pathway, aspirin, anticoagulation per protocol, and cardiology activation. Do not wait for the troponin to become positive. This schematic shows an inferior STEMI pattern. The classic leads are 2, 3, and AVF with reciprocal depression in AVL. If lead 3 has more ST elevation than lead 2, think right coronary artery involvement. The most common cause of inferior STEMI is RCA occlusion. If the patient is hypotensive or has ST elevation in V1, think right ventricular infarct and get right-sided leads. The classic finding is ST elevation in V4R of at least 1 millimeter. The major board trap is giving nitroglycerin to an RV infarct patient who is preload dependent. That can drop the blood pressure fast, resuscitate, avoid preload crashing medications, and activate the reperfusion pathway. Posterior MI is one of the classic missable ECG diagnoses. The posterior wall is electrically hidden on a standard 12-lead ECG, so the tracing gives you a mirror image. Look in V1 through V3 for horizontal ST depression, tall R waves, and upright T waves. If you see that pattern in the right clinical context, place posterior leads V7 through V9. The trap is calling this just NSTEMI and delaying reperfusion when the patient may have an occlusion MI. The classic distractor on the exam is the stem that emphasizes ST depression in V1 through V3 and asks for medical management. The next step is posterior leads, not a heparin drip. Posterior MI is usually a left circumflex territory event. This schematic shows a non-ST elevation ACS ischemia pattern. You may see ST depression, dynamic T-wave inversion, or transient ST elevation that resolves. Diffuse ST depression with ST elevation in AVR should raise concern for left main, proximal LAD, or severe multivessel ischemia. The ECG can also be normal early, which is why serial ECGs are part of the evaluation. NSTEMI does not mean low risk. The risk comes from symptoms, ECG dynamics, troponin pattern, hemodynamics, arrhythmia, and comorbid disease. Wellens and de Winter patterns are high yield because they test whether you can recognize occlusion risk without classic ST elevation. Wellens is biphasic or deeply inverted T waves in V2 and V3, often after pain has resolved with a near-normal troponin. It signals critical proximal LAD stenosis, and the classic distractor is stress testing the pain-free patient. Do not stress test Wellens. The next step is Cath. De Winter T waves are upsloping ST depression at the J point with tall symmetric T waves in the precordial leads, representing proximal LAD occlusion equivalent. These are Cath conversation patterns, not reassurance patterns. Here is the de Winter concept more visually. The patient may not meet classic STEMI criteria, but the pattern is dangerous. Upsloping ST depression at the J point with tall symmetric precordial T waves. This is a STEMI equivalent or occlusion MI pattern in many teaching frameworks. The practical ED move is not to wait calmly for a second troponin if the clinical picture fits. Get cardiology involved early and treat this as a potential LAD occlusion. Left bundle branch block and paced rhythm make ischemia harder, but not impossible. The Sgarbossa criteria look for 3 findings. First, concordant ST elevation of at least 1 millimeter in any lead. Second, concordant ST depression of at least 1 millimeter in V1, V2, or V3. Third, by the Smith modification, excessive discordant ST elevation, defined as an ST to S wave ratio of negative 0.25 or worse, meaning the ST elevation is at least 25% of the depth of the preceding S wave. The classic original Sgarbossa cutoff was 5 millimeters of discordant elevation, but the Smith modified ratio is the more sensitive board-favored rule. The core idea is that the ST segment should be appropriately discordant in bundle branch block. When the ST segment is concordant or excessively discordant, that is a dangerous pattern. Clinical context still matters, and a sick patient with concerning symptoms deserves early cardiology discussion. STEMI mimics are important because both errors are dangerous. You can activate the cath lab unnecessarily, but you can also dismiss a real occlusion as a mimic. Pericarditis tends to show diffuse concave ST elevation with PR depression and no territorial reciprocal depression except possibly AVR or V1. Early repolarization is usually stable, and in a benign context, often a young patient with notched J points. LVH, left bundle branch block, and paced rhythms require proportional thinking. Brugada shows a pseudo-right bundle pattern with domed ST elevation in V1 and V2. LV aneurysm gives persistent ST elevation with deep Q waves weeks after an old anterior MI. Takotsubo cardiomyopathy is the post-stress apex ballooning pattern that mimics anterior MI in an older woman after emotional trigger. Hyperkalemia is the mimic that can kill before the cardiologist arrives, with peaked T waves, QRS widening, bradycardia, or conduction delay. When in doubt, treat the immediately dangerous physiology and repeat the ECG. Hyperkalemia deserves its own slide because it is a classic ECG mimic and a resuscitation emergency. Tall peaked T waves, PR prolongation, QRS widening, bradycardia, and conduction blocks should make you think potassium. The ECG changes are often diffuse rather than territorial. If the patient has renal failure, missed dialysis, ACE inhibitor use, or a compatible history, treat immediately. The next step when you see peaked T waves with a wide QRS is IV calcium for membrane stabilization, then shifting therapy with insulin plus dextrose, and finally potassium removal with dialysis. The classic distractor is reaching for sodium bicarbonate or albuterol first when calcium is the life-saving move. Do not anchor on ACS when the ECG is global and the patient is telling you potassium. Medication anchors matter, but sequence and contraindications matter more. Aspirin is 325 mg chewable unless there is a true contraindication. Nitroglycerin is commonly 0.4 mg sublingual every 5 minutes up to 3 doses, but avoid it in hypotension, suspected right ventricular infarct, or recent PDE5 inhibitor use. Unfractionated heparin is a bolus of 60 units per kilogram, maximum 4,000 units, followed by an infusion of 12 units per kilogram per hour, maximum 1,000 units per hour, titrated to institutional protocol. Enoxaparin is 1 mg per kilogram subcutaneously every 12 hours, adjusted for renal function. Oxygen is for hypoxemia or respiratory distress, not routine normal saturation. Morphine is selective for refractory pain and is not the default first medication. The board tests nitroglycerin traps, especially inferior MI with right ventricular involvement. For STEMI, the algorithm is reperfusion. If the ECG and story fit STEMI or a STEMI equivalent, activate the reperfusion pathway immediately. Primary PCI is preferred with a goal of first medical contact to balloon within 90 minutes, or door to balloon within 90 minutes if the patient presents directly. If transfer is required, PCI is still preferred when total time to balloon can be achieved within 120 minutes. If PCI cannot be delivered within that window and the patient has an eligible STEMI without contraindications, fibrinolysis is indicated with a door-to-needle goal of 30 minutes. After lysis, monitor for reperfusion and arrange rescue PCI if reperfusion fails. Shock, arrest, or mechanical complications require resuscitation, cath lab coordination, and ICU level care. Do not wait for the troponin when the ECG is already telling you STEMI. NSTEMI and unstable angina require risk-based management. Start aspirin, anticoagulation per protocol when appropriate, symptom control, serial ECGs, and serial troponins. High-risk features include recurrent pain, dynamic ECG changes, a rising troponin, hemodynamic instability, ventricular arrhythmias, heart failure, or concerning comorbid disease. Those patients need cardiology involvement and an invasive strategy. The standard timing framework is an early invasive strategy within 24 hours for high-risk patients, including those with a GRACE score greater than 140, dynamic ECG changes, or rising troponin. An invasive strategy within 72 hours is appropriate for intermediate risk patients. Immediate cath, like a STEMI, is reserved for refractory ischemia, hemodynamic instability, life-threatening arrhythmia, or mechanical complication. Low-risk chest pain may enter an accelerated diagnostic pathway, but only after high-risk history, ECG, and biomarker features are absent. Risk stratification tools help with low-risk chest pain decisions, and the heart score is the most board relevant. Heart stands for history, ECG, age, risk factors, and troponin, each scored 0, 1, or 2 for a total of 0 to 10. A score of 0 to 3 is low risk, with a major adverse cardiac event rate at 30 days of roughly 1 to 2%. And these patients may be considered for an accelerated discharge pathway with shared decision-making and close follow-up. A score of 4 to 6 is intermediate risk, warranting observation, serial troponins, and further evaluation. A score of 7 to 10 is high risk, requiring admission and an early invasive strategy discussion. The heart score does not replace clinical judgment, and it does not apply to patients with active ischemia, hemodynamic instability, or a clearly abnormal ECG. The board trap is using heart to discharge a patient with a concerning story or dynamic ECG. Antiplatelet and anticoagulation strategy depends on the pathway. Aspirin is early unless contraindicated. P2Y12 medication choice and timing depend on whether this is STEMI, NSTEMI, cath lab now versus delayed invasive strategy, bleeding risk, and institutional protocol. The current standard P2Y12 agents are ticagrelor or prasugrel layered onto aspirin. Glycoprotein 2B3A agents like eptifibatide and tirofiban are largely declining and are no longer the routine first move. Anticoagulation options include unfractionated heparin, enoxaparin, or bivalirudin, depending on local practice and renal function. The major ED caveat is dissection. If aortic dissection is plausible, do not reflexively anticoagulate before you evaluate it. The goal is to balance ischemic benefit against bleeding catastrophe. Nitrates are useful for pain and blood pressure relief, but they are not harmless. Avoid them in hypotension, suspected right ventricular infarct, severe aortic stenosis, and recent PDE5 inhibitor use. The classic distractor is nitroglycerin for an inferior STEMI patient who is preload dependent. That is the answer that crashes the blood pressure. Beta blockers may help selected patients, but avoid them in acute heart failure, shock, bradycardia, high-grade heart block, or severe reactive airway disease. Oxygen is for hypoxemia, respiratory distress, or shock, not routine normal saturation. Treat pain, but do not let pain relief falsely reassure you if the ECG or physiology is worsening. ACS can deteriorate fast. Cardiogenic shock is hypotension and hypoperfusion from pump failure until proven otherwise. Arrhythmias include VT, VF, bradyarrhythmias, and AV block in inferior MI, and atrial fibrillation from ischemic stress. Mechanical complications include papillary muscle rupture, ventricular septal defect, free wall rupture, and tamponade. Bedside echo can change management by showing LV function, RV failure, tamponade, or clues to a mechanical lesion. Unstable ACS is resuscitation plus reperfusion. It is not just medication order entry. Special populations create board traps. Women, older adults, and diabetic patients may not present with classic crushing chest pain. Renal failure complicates baseline troponin interpretation and affects anticoagulant dosing. Cocaine and stimulant-associated chest pain is treated with benzodiazepines and nitrates. Be cautious with pure beta blockade and acute toxicity when that is a concern. Post-operative or anticoagulated patients may still have ACS, but bleeding risk changes the strategy. And always keep aortic dissection in mind when the story includes tearing pain, pulse deficits, neurologic deficits, new aortic regurgitation, or other dissection clues. Disposition is the final expression of risk. Cath lab now for STEMI, STEMI equivalent, or unstable high-risk occlusion concern. ICU or CCU for shock, significant arrhythmia, respiratory failure, mechanical complication, or ongoing ischemia. Monitored admission for NSTEMI, dynamic ECG changes, recurrent symptoms, or high-risk history. Observation pathway is for low or intermediate risk patients who need serial ECG and troponin testing. Discharge is only after a structured low-risk pathway and safe follow-up. A single normal ECG and one early troponin are not a discharge plan for a high-risk story. Boards test ACS by offering the right diagnosis with the wrong sequence. Posterior MI gets mislabeled as NSTEMI. Inferior STEMI with right ventricular involvement gets nitroglycerin and crashes. Wellens gets stress tested. De Winter is missed because there is no obvious ST elevation. Hyperkalemia gets treated as ACS only, and a high-risk patient gets discharged after one negative troponin. The exam rule is that the correct answer either prevents a missed occlusion or avoids a harmful medication. Stress testing Wellens is the wrong answer. Case 1. A 64-year-old man presents with crushing chest pain, diaphoresis, and hypotension. The ECG shows ST elevation in leads 2, 3, and AVF with reciprocal depression in AVL. Lead 3 has more elevation than lead 2. This is inferior STEMI, with concern for RCA occlusion and right ventricular involvement. The next steps are aspirin, Cath lab activation, a right-sided ECG to look for ST elevation in V4R, and careful preload support with crystalloid boluses of 250 to 500 milliliters, titrated to blood pressure and lung exam. The avoidable mistake is giving nitroglycerin to a hypotensive RV infarct patient. Case 2. A 72-year-old woman presents with dyspnea, nausea, and diaphoresis rather than classic chest pain. Her ECG shows dynamic ST depression in V4 through V6 and the inferior leads. Her initial troponin is mildly elevated and then rises. This is NSTEMI until proven otherwise, and it is not low risk. Management includes aspirin, anticoagulation per protocol, serial ECGs and troponins, cardiology involvement, and monitored admission. Do not discharge because the pain improved. Case 3. A 58-year-old patient has ongoing chest pressure and diaphoresis. The 12-lead ECG shows ST depression in V1 through V3 with tall R waves and upright T waves. There is no classic ST elevation. This should trigger concern for posterior MI. The next step is posterior leads V7 through V9 and early Cath discussion if the clinical story fits. The trap is treating it as low-risk NSTEMI because the word STEMI never appears on the computer interpretation. Question 1. A patient has inferior STEMI, hypotension, and ST elevation in lead 3 greater than lead 2. Right ventricular infarct is suspected. What medication should be avoided? The answer is nitroglycerin. Right ventricular infarct patients can be preload dependent, and nitrates can cause severe hypotension. The board trap is treating chest pain reflexively without recognizing the infarct territory. Question 2. A patient had chest pain that is now resolved. The ECG shows biphasic T waves in V2 and V3. The first troponin is negative and the patient feels better. What is the next best step? The answer is admission with urgent cardiology evaluation. Do not stress test this patient. This is a Wellens pattern until proven otherwise, suggesting critical LAD disease. The trap is being reassured by pain resolution and a negative early troponin. Question 3. A patient has ongoing chest pain. The ECG shows ST depression in V1 through V3 with tall R waves. What is the next ECG step? The answer is posterior leads V7 through V9. Posterior MI can appear as a mirror image STEMI on the standard 12-lead ECG. The trap is calling it non-specific ST depression and missing an occlusion. The final takeaways are these. Activate reperfusion for STEMI and STEMI equivalent patterns. NSTEMI can be high risk when there are dynamic ECG changes, a rising troponin, recurrent symptoms, instability, arrhythmia, or heart failure. Posterior MI, right ventricular infarct, Wellens, De Winter, and modified Sgarbossa patterns are classic board traps. Medications help when used in sequence, but they harm when contraindications are missed, and a normal first ECG or first troponin does not end a high-risk chest pain evaluation. One negative troponin is not a disposition. References for this lecture include Rosen's Emergency Medicine, Foundations of Emergency Medicine Board Review, the 2025 ACC, AHA, ACEP, NSTEMI, and SKY Guideline for Acute Coronary Syndromes, and the Life in the Fast Lane ECG Library for ECG Pattern Review. The ECG images in this lecture are original schematic teaching visuals, not reproduced patient ECGs. Use local Cath lab activation criteria, anticoagulation protocols, and institutional chest pain pathways for operational details.